If I'm not talking loud enough, just tell me. I yell loud enough to my kids, but I might not talk loud enough here. And if I'm going too fast, that's another thing my husband yelled at me about. Don't go too fast. So basically, just a little bit about myself. I'm a physical therapist. I've been a therapist 31 years, but prior to that, I actually was a physical therapy assistant. I practiced for about 2 years as a physical therapy assistant, and then I practiced a little bit while I was in PT school. So, and now I had my bachelor's in physical therapy, and I'm currently pursuing my doctorate. Why, I don't know. I'm getting older, but I just decided maybe it was a good idea. Jeff helped me a lot. I've known Jeff for about Professor Leatherman for about 20 years probably. I thought about that and I said,
it's a long time.
Yeah, it's a long time. So he asked Tiffany and Professor Tiffany and Professor Jeff asked me to do this lecture. So I'm doing a lecture on women and men's health. I basically wanted to just highlight a few things that I think is really important in the clinical setting. Currently, I do home health. I've been doing that about 15 years, but I have done everything. I've done hospital, I have done rehab, I've done skilled nursing SNFs. I have done probably almost everything, but I really currently enjoy home health. I think that's the place for me. I think you need some experience before you go to home health, because in the home you don't have a lot of help. But so I kind of mixed a lot of things that are more common sense things, but you need to know them, especially any facility you're at. The doctors spend, and I'm sure you've heard this 100 times, 5-10 minutes with the patient. We spend a lot more time with them. Things happen during the time we're spending time with them. As assistants, you need to tell your therapist you spend more time with them than the therapists do. And then they have to be relayed to the doctor. There's so many things that put these patients back in the hospital, and it happens quick. It's not a slow thing. So I'm going to talk about breast cancer, prostate cancer, and kind of lump that into what we need to do as therapists. And then I'm going to talk about incontinence and what that, urinary incontinence and urinary tract infections, which I know you've done some clinicals, so that is a big, put them back in the hospital, mental changes, and adds to a fall. So you really have to pay attention to those. And I'm going to talk a little bit about osteoporosis, which is another thing, because if they're falling, they're breaking something if they have the osteoporosis. And then I'm going to talk about some fall risk and fall prevention things. And at the end, why you put your name in the hat is because we're going to pull 2 names from the hat, and we'll just go until somebody gets the answers right. And then I have T-shirts for whoever the 2 people are that get the answers right from the questions, some of the things that I lecture on. Not big things, but very common sense things, okay? So we'll start with cancer-related illnesses. Of course, breast cancer mostly begins in the fatty tissue. It also occurs in the surrounding lymph nodes, especially those of the underarm. It's in milk-producing ducts and glands are the 2 most likely areas. Most common diagnosis in cancer in women. Second leading cause of cancer, death among women. 246,000 women are diagnosed a year, 40,000 will die. 2,600 men will be diagnosed. Approximately 440 of those will die. And men are just not apt to say, because it's not as likely in them. Breast cancer most commonly spreads to the bones and lymph nodes, and that's what I really want to emphasize here. At the same time, I am going to tell you, I am a breast cancer survivor. To add everything else to and I have 3 children too, but I am 7 years free of breast cancer. It was early diagnosed, but I can assure you, after my radiation treatment, I had tightness in my shoulder. That winter, I thought, I stretched and stretched. Now I know why women get frozen shoulders and adhesive capsulitis after they have breast cancer. And so I stretched and stretched and thought, and it hurt too. But then that next year I thought I'm in for it again, and guess what? I didn't have the problem. So tell your patients, give it time. Give it time is one of the things that I don't think people understand. Sometimes it does take a year to get totally better to where you need to be. My physician at the time, my surgeon, I had my surgery in June. The following June, she said to me, "This is your new normal." I said, "Okay, I can live with this." And then I said to her, "But it still hurts sometimes and it's still tight." She said, "Well, I didn't do a lot to you." I said, "Well, I'm a physical therapist. Why would I lie?" So it was kind of a cute thing that happened. But be aware that, it does travel, and that's the important thing. And it can travel years later. It doesn't have to be at that time. And then for men, prostate cancer is the most common type of cancer in men. There are no early symptoms of prostate cancer. Prostate cancer, and I changed this, so you might want to change it in your notes if it matters, is diagnosed in an estimated 23% of the men who reach 75 in the U.S. Because I kept thinking 80% is an awful lot. So I looked that up again. And then prostate cancer most commonly spreads to the bones and lymph nodes. So both cancers commonly spread to the bones and lymph nodes. So when you are treating patients with a past medical history of the two types of cancer, make sure you consider a possible cancer in the site you are treating. If no resolution of pain or unusual pattern of pain, especially bone pain, common pain complaint of cancer patients is night pain that never resolves and gets worse. So these will travel. These are the two that will travel. So please be aware of that. If you have shoulder patients aren't getting any better, think about it. If you have back patients not getting any better, think about it, okay? Because it could be that they have a tumor somewhere. But look for those things, and night pain is the real emphasis with that. Osteoporosis is the next thing I wanted to touch on a little bit. Osteoporosis, or thinning of the bones. About 200 million people have osteoporosis and can result in painful fractures. Most common reason for fractures in a bone among the elderly. Minor stress can cause the fractures. The most common regions include the backbone, which is the compression fracture, and everybody knows Tony Romo, of course. Now he's been getting the steroid injections, and so the epidural, because during halftime they've been doing that in his back. So what do you think at this point? He's probably had enough steroid epidural injections that he probably has some osteoporosis showing up, softening in his bones, because it's unusual for someone his age to get a compression fracture. It really is. But anyway. Those common regions include the backbone, the compression fractures, the forearm, the hip, the wrist, and the ribs. Minor stress, again, can cause the fracture. Osteoporosis more common in women than men. In the U.S. in 2010, about 8 million women and 1 to 2 million men have osteoporosis. 70% of those over 80 are affected. And again, I put in more common in women and men, so that was my fault. It was a repeat. The important thing to remember, it's occurring in men more because they're having transplants and they're putting them on steroids, and that is creating the osteoporosis a lot more in men. So, be aware of that. Bone density testing is important, especially if someone had a fracture in a common osteoporosis site above. So, be careful. A lot of these women don't have bone density tests, or a lot of these men, and they're at the age where they should be having it, especially if they broke their wrist and they just hit it somewhere, they didn't fall on it, or you start to see these patients and you ask them, have you had a bone density test recently? Because some of them are not on the preventative care of it. So you want to make sure that, and when you're treating them, you have to know they have osteoporosis. It's very helpful in everything we do with them. And the treatment includes calcium, vitamin D, and exercise. Weight-bearing endurance exercises and/or exercise to strengthen muscles, improve bone strength. This with osteoporosis. Aerobics and resistance exercises all maintain or increase bone mass density in postmenopausal women. Now, I would say low impact aerobics. I would say, I wouldn't recommend the high impact, but that's what I got from the information. In the US, more than 250,000 hip fractures annually are attributed to osteoporosis. It's a really tough, it's a really hard thing. We're not seeing it in the younger generation as much anymore. As we move on, we're not seeing the Dowager's hump and and the other thing I wanted to add in treatment was postural exercises. That's another thing that I added to that, because it is important, especially for, the women that you see with the bad Dowager's hump. Although, because they're doing the vitamin D and the calcium, we're not seeing as much of that, which is a good thing, because those women, that also contributes to falls because they're so off balance with all of that. Okay, and the compression fractures. Just one other thing about the compression fractures, they are doing the kyphoplasties. Really, they put the cement, they actually inject the cement into the area. A lot of anesthesiologists are doing it now. But the problem is that for some reason, they're saying if they're doing multiple levels now, it's not good, that it creates problems in the spine. So, but what I saw from a lot of my patients, that immediate pain relief is wonderful, because those compression fractures are quite painful. Okay. Urinary, I don't know, has anybody seen patients with compression fractures at this point in the clinics? Urinary incontinence and urinary tract infections. If I had to pick my biggest thing in home health, it's the UTIs. Big problem. Urinary incontinence, a common problem in women and men over the age of 65. 1 in 10 adults over 65 have a problem with urinary incontinence, and you wouldn't know it because your patients won't tell you either a lot of times. Especially the younger ones, they kind of want to hide it a lot. There are 5 types: stress incontinence, urge incontinence, overflow incontinence, functional incontinence, and mixed incontinence. I didn't go over all of them. You can look them up, and I'm sure you're learning them from, Jeff and Tiffany. The most common, though, is the overactive bladder, which is the stress incontinence where they have to go to the bathroom a lot. There are treatments for urinary incontinence, and there are things to tell the patients: drink less caffeine, alcohol, do not drink late in the evening. They use certain exercises such as the Heatlh exercises, medication, electric stimulation. It's not one of the areas that I like, but because I see so many patients, I use the basic things. Don't drink after 7 o'clock at night, because they fall a lot when they have to get up in the middle of the night to go to the bathroom. That's a big fall time for these patients. So you have to, whatever the knowledge you have is helpful, better than saying nothing. Now, the urinary tract infections. There were 10 million physician office visits in America in 2002 for UTIs. Women are the most common. 30 to 40% of elderly patients with serious UTIs do not exhibit symptoms, and that's one of the problems. But I got to tell you, and it's in one of my symptoms, you cannot miss that smell. If you've ever taken a patient to the bathroom in a SNF, in an assisted living facility at their home, that smell will knock you over. And so you've got to tell the nurses right away, or the family, because there's got to be an intervention, because they will get worse, believe you me. And then they'll they'll have mental status changes, and then they'll fall. And then they'll be in the hospital. The reason for UTIs: decreased immune system due to aging, bladder muscles are weaker, less efficient bladder emptying, do not change depends, pads, diapers often enough, they stay moist. And that is huge, because if they're moist, the bacteria grows in there, and it is a real problem. So try to get your patients to change their you know, pads and whatever more often, or the nurses, you know. I'm after, you know, you have to be after them all the time in the SNFs and the other places because they just ignore it a lot of times. And you do it. I mean, unfortunately, I've been doing this 31 years. My first 3 years, I spent a lot of time in the bathroom with my patients, and that's all I'm going to say about it. Individuals with catheters, stagnant urine. So if someone's been in the hospital and they've had a catheter and then you get them in rehab, be aware that it can hit that late because it's growing. So if you know they've had the catheter and you're either doing home health or you're in the clinic, be aware that that's a possibility. The common symptoms of UTIs include frequent urination, burning or pain with urine, low-grade fever, odor of urine, and I wrote again, you cannot miss that smell, I promise you. Blood in the urine, but by the time it gets to blood in the urine, it's pretty bad, it's pretty up there. Urine that appears cloudy, causes delirium, confusion. Many elderly individuals end up in the hospital or falling due to the UTIs that go undetected. Please watch your patients closely for UTIs. If you see a change in their behavior or mental status, notify the physician, nurse, facility, or family. It is very important to prevent and treat UTIs. The treatment includes antibiotics, and now they're even doing some preventive antibiotics. And when I worked in the Charlotte area, that was wonderful. It was really preventing the UTIs. So please be aware of that, because some of the doctors aren't doing it yet in the area, this area, and I work in Virginia. They do not, you know, and I'm starting to get the doctors to do it because I know of it, because I've had repeated UTIs with people. So be aware, you know, it doesn't hurt to suggest the preventative low-dose antibiotics that keep them away. People in their 80s and 90s aren't going to get immune to antibiotics if they're low dose. And they are doing a lot in Charlotte, and it's working. Drink cranberry juice, take cranberry supplements. If no history of kidney stones, you just don't want to drink cranberry juice if you have kidney stones. And people have a lot, but they drink a lot of cherry wine here. I don't know if I said that right. I think it's supposed to be cherry wine. I'm not quite sure. But anyway. But I don't have that southern accent. I'm originally from Philadelphia. Fall risk and prevention. About a third of the elderly population age 65 fall each year. At 80 years and over, half of the seniors fall annually. Many incidents go unreported by the elderly. What you will find is it takes a lot to get out of them that they've fallen. Nobody will tell. So their numbers are not even accurate because they won't tell you. And that 705 should be 70% of fallers are female. I apologize about that. So it should say 70% instead of 705. And then it's the 5th leading cause of death in the elderly. And mostly, believe it or not, the worst thing that happens is they hit their head. They get a subdural hematoma. They die more from that than a hip fracture. They're better off fracturing their hip than hitting their head. That's the most dangerous. Individuals that frequently fall are 2 to 3 times more likely to fall again. They become fearful of falling, and it will happen again. And so you've got to intervene with balance and education, and it makes a difference if you do. Falls account for 25% of all hospital admissions. The cost of treating fall injuries in the elderly as of 2013 is $34 billion. It really is up there. Getting assistance quickly following a fall improves the chance of survival by 80% and increases the likelihood of return to independent living. If you look at that fall sheet that I gave you, the handout, they're really good for patients. And if you look, it talks about what to do. There's a few pages, if you keep going, that give you pictures of what to do in a fall. I'm sorry, I didn't have, I couldn't get it to copy as well on the bottom, but that's a good one for patients, what to do once they've fallen. So I gave that to you so you could, use it if you needed to in the future. fall prevention in the elderly is extremely important, as you see the statistics. In physical therapy, we play a big role in preventing falls, patient recovery following a fall, and preventing reoccurring falls. Treatment includes fall prevention education, and like I said, that front handout too gives you things to give to your patients as well. You know, basic stuff that they need to do to prevent the falls. And calling fall prevention education, what to do if a patient falls, calling for assistance following a fall, balance training, and other forms of gait training with assistive device and exercises, including a home exercise program. A lot of people are proud, they don't want to use canes, they don't want to use walkers. Please, you know, get them to be cooperative with it. You know, explain to them the importance of those assistive devices. People are living, I've had 100-year-olds at this point. I've had about 300 or 400-year-olds that are still pretty functional, believe it or not. Lots in their 90s, but they need to be safe, and it is a problem. Some falling prevention interventions include having a flashlight available if the electric goes out by your bed, especially using a night light. Removing throw rugs, clutter in the home, slow position change when you get up out of bed or from a chair, to have a telephone, cell phone, or an alert device to push if you have fallen. In home health, it is easy to detect these problems and improve them for me. But in outpatient or other facilities, please ask the patients and discuss fall prevention for when they are going home. This links fall prevention with UTIs. Need to catch UTIs early, which can cause falling due to mental status changes and weakness. Please remember, with an elderly population growing and growing, prevention is the key. And I just had a few other things. In the long-term facilities, I don't know if any of you saw it in your clinicals, but they are using hip pads now. Once a patient falls, they're real uncomfortable. The patients don't like it, but it decreases falls about 50 to 60%, which is really good. So if you're in a facility and you have a patient that fell in the facility while you're there, ask them, do they have hip pads? They pad their hips so that when they fall, they don't, the pad takes some of the cushion so they might not fracture their hip. So that's a big, 50 to 60% is a big amount. And then home safety assessment, reduce falls by 25%. Some of the skilled facilities do home assessments. That would be great if you go to one and your clinical, whoever's your supervisor is going on a home assessment, go with them, because you want to know that. But if you're in the outpatient, if you're in a SNF, please, these are questions that need to be asked. Anybody that's been in a SNF, because I haven't been in the clinic for a while, do they ask all these questions? Do they give a sheet to the patients or their family? Okay, so they do that now, okay. Do they do home visits still? Some of them do, some of them don't. Not as much. It really does help when they do, especially the rehabs will do it. And if you've ever been on one, it's really, it's amazing what you see in the home that you don't see in the SNF or the clinic or the outpatient. And strength and balance activities are beneficial, but only if they're continued, and hence home exercise program. Please, even if your therapists don't do it, please give them a written home exercise program. It's golden. And I believe in it. I do it the first visit I do in home health. I'm a big one, and I know if somebody's doing it or not, and that if I see in a week or so they're not getting better, I know they're not doing their home, because I'm only going there twice a week, 3 times at the most. They have to do it. But there's nothing better you can do for them when they're leaving the SNF, when you're seeing them in outpatient. Hand them a written home exercise program. Tell them to put it on their refrigerator. I am such an advocate for it. I think nothing like educating your patients. That's our job, really. We are educators. We're not going to be in their life forever. We have a short time to treat them. In that time, we have to use everything we can to be an educator. We are a teacher. And it works with some, and it doesn't work with others, but the ones that tell me that I know are not going to do it, I call them a month later. I'll call their house. I tell them I'm going to call them, and they think I'm not. And when they get that call, they're scared to death. Well, what do you call me for? Did my doctor make you call me? I said, no. So it is, I can't tell you how important it is. I see that as something that is extremely important for patients. And I'm sure that was shorter than I expected, but does anybody have any questions? I mean, I'm sure you've had a lot of advice on these things, but I can't emphasize them enough. I can't tell you, every day a patient of mine falls in the home, every day, or at least 2 a week. It's unbelievable how bad it's gotten. And a lot of them have been in SNFs and rehabs, you know, for like 2 months, but they come home, and some of them don't do a home visit, and before I can even get in the house, sometimes they've fallen because they don't have the commode in the right bedside commode in the right place. They get up in the middle of the night to go to the bathroom. They don't have flashlights by their bed. When you're an outpatient, when you're in the SNFs, please ask those questions, because I'm in the home, and I can tell you when they get home, they don't have those things. So please, can't emphasize the importance. Okay, does anybody have any other questions? Okay, now I have to find where Tiffany put the hat.
It's in the back.
In the back table.
Okay. And believe me, this is basic things, but I can't, being a home health therapist, you know, I can tell you the importance. Okay. Now this way I'm not cheating, but I'm gonna let somebody else pull from the hat. You've been very good and listened very closely, so I'm gonna let you pull a name. Oh, okay, he took the first one. Do you know who that is?
Chelsea.
Okay, Chelsea. Who's Chelsea? Okay, Chelsea. It really, well, I'm going to take this off. Okay, just real quick, okay? If somebody had a UTI, name me 3 symptoms that you would look for if you suspected they might have a UTI.
Confusion, smelly urine, and cloudy urine.
Okay. See, I didn't, it wasn't going to be hard. All right, you ready? Are you a good catch, Chelsea? Oh, there you go. Good job. Okay. All right. One more. I'll let you pick this time. Allison? Okay. Allison. Who's Al? Okay, Allison. That's my niece's name. But anyway, real quick, 3 things that you would do to prevent falls.
You could strengthen them for, if they were just weak, you could strengthen them so that they wouldn't fall. You could use a nightlight, and like if they have a UTI, tell them not to drink after 7 o'clock, because if they have to get up during the night to use the bathroom, they're more likely to fall than if it's during the day.
Okay. Very good. All right. There you go. Now, the other thing is that, there you go. Oops, sorry. I have one more thing for you guys, because I can't tell you how important. If you do your job in the rehabs and SNFs, then home health becomes so simple. There's 2 of you here. If you could pass the other one on. Do you need one more? Oh. I'm sorry, what'd you say? Oh, okay. You're welcome. And there's reasons for these, because if you look in, I'm getting you started on what you need for. There you go. And I just threw a couple extra, but that's how important I really. Now the cookie's the best.
Appreciate it.
That's the best. Professor Leatherman will tell you that, but seriously, that's how important. And they all work. I put batteries in them, and the nightlight only works at night, in the very dark.
I'm about to trade a nightlight for a cookie.
But anyway, I mean, you know, Jeff will tell you I'm kind of like that, but it is, if you guys guys do your jobs in the facilities, then my job becomes so much easier. Have any of you had the opportunity, have anybody had the opportunity in home health at all yet? Well,
I did.
what did you think the difference was in the clinic compared to home health?
You gotta know what you're doing because you don't have nobody to ask or, where you can make a call or whatever, but it's different.
You have to,
You have to use your imagination a lot.
yeah, there you go, you have to be, and safety. You can't believe how unsafe some of these people are, dogs running around, different things.
How much of your work do you take home with you
Well,
on a daily basis?
that's interesting. How, like to do computer work and paperwork and things like that. It's less than it used to be, but it's still a lot. As an assistant, you have to do the notes. You don't have to do the evals and starts of cares and things like that. So in that way, it's a good thing. You'll have less paperwork. I do most of my note in the home. I honestly have to say, I do most of my note in the home. Sometimes I have to do some of the just the paragraph at home because these people are talking to you. I'm older. I can't do the computer and listen at the same time. But I do take work home with me. And I have doctors calling me. Some of the doctor's offices are open late, so they'll call me at 7 o'clock at night sometimes. So you do. The patients will call you at 6 in the morning. So try not to, that's where a work cell phone's really good in home health because they'll just, it's all about them. So you have a hard time with that sometimes. But I would say 25 to 35% I end up doing at home at night. But some nights are good where I just have to do notes and then that's maybe 20 minutes, 25 minutes. So you just have to, whatever you can get done in the home before you walk out of the home is your best bet. But even in outpatient, everywhere now, the demand of what we have to do note-wise is really getting tougher. And I don't know what to tell you guys. Just do the best you can, get it done as best as you can. The computer systems they say they're physical therapists that are doing them. I don't believe that. I think they're computer people and they're just, whatever we tell them to do, they're putting into the system. And so it becomes very challenging. There are a few systems out there that I just can't handle. There's so many parts to them. You have to go all over the place. So, when you're interviewing, ask about their computer systems because that does become a big thing. But I try not to do too much at home now. I've gotten better at it because I know that it can get overwhelming. But it's a problem, outpatient, anything anymore. I think the paperwork, and I say this very kindly in a way, becomes more important than the patient. And we have to stay focused. We're to care for the patient. And so you can ask my patients. When I'm in there, your eyes and your ears do not deceive you. Pay attention. Put the computer aside, because in the end, what the patient says about you is more important. Because I've had patients say that other therapist is on her cell phone the whole time, texting, or they're on the computer the whole time. And I just leave it alone and I don't say anything about it. It's not my business, but that's the truth. They will notice it and they will tell the next person that comes in there what's going on. So I leave my cell phone in my car. Unless I have a doctor calling, my cell phone does not come in the house. Maybe if I feel in danger, but that's a rarity in home health. It really is a rarity. I mean, I've been in 1 or 2 homes that I can say I left because there was issues, but I do not bring my cell phone. I think that's distracting to me, distracting to the patient. So, but otherwise, do the best you can. You seem like Jeff says wonderful things about you. So just go in and be enthusiastic and enjoy what you do. And hopefully it'll give back to you. That's one thing that's wonderful about our field. Well, I hope I've made this fun. When I came in and I don't know her name, Heatlh, I thought she's going to do a much better job than me. I just like to have a lot of fun, but I enjoy what I do, and that makes a difference. Thank you so much.